Is everybody right to see that now? Yeah, thanks, Sarah. And welcome back from Singapore. I hope you had a good time.
Oh, Singapore, awesome.
She did, yeah, great.
Thank you for giving acknowledgement of country. Goals for today. Oh, okay, our sound is through the room.
Yeah.
Okay, sorry, saw we were muted. All right, so we're gonna do a 10,000 meter view of study designs. We're gonna learn about briefly the qualitative methods and then also talk about potential sources of bias. As Meg said, this is gonna be a really quick overview because there's so much about this topic. So this is where we're at, research methods. We did implementation strategies the other time, if you remember, which is that other box. And then we did unintended consequences, which affects all of this, but. All right, so when you're selecting a study design, so say you're implementing your digital health technology, it's really gonna depend on your research question. So what are you asking? And in implementation science, you typically are pulling from other disciplines, except for effectiveness implementation hybrid designs. Those are kind of unique to implementation science. And I will talk about those study designs later in this presentation. So when you're selecting it, you're gonna, what research questions, you're gonna think about the feasibility of data, feasibility of personnel and time. Your setting, your funding, what type of intervention is it, the logistics to get it implemented, population you're working with, timeline, ethics, and available data. These are all gonna go into that whole, what study design you're gonna do. And I'm gonna break it down just into 4 categories, but we can talk more on that, but there's experimental, observational, we have qualitative, and then the mixed methods. I think a lot of digital health projects are going to be mixed methods, but it's good to have an understanding of experimental and observational so that you can combine that with qualitative. Okay, so this is a lot here. I'm gonna walk through this. So a randomized controlled trial. This is kind of the gold standard of evidence. It's what everyone wants to do, but it's very challenging. It's really challenging to do in a healthcare setting as well, unless you have a lot of funding and logistically and just staff and personnel. But there are other types of RCTs you can do. There's a cluster randomize where you randomize on the group level. So maybe you do it by clinic or hospital. There's randomized encouragement where you could have patients randomly assigned to receive encouragement to try it. So that could be, maybe you have it randomly assigned that patients are encouraged to use a mobile app, for example. And then there's a pragmatic RCT, and this is where the intervention is delivered in a normal setting, and you're trying to test the benefit in routine practice. So you're kind of getting patients who receive the intervention versus just usual care. And with a pragmatic RCT, it could be something like all the patients who come in for their routine diabetes care are randomly assigned to receive a new type of intervention, like a phone call from a nurse, a phone call from a nurse on the healthcare team or something. It's something like that. You're not taking away usual care, you're kind of adding on to usual care. And experimental designs prioritize internal validity, which is that cause and effect claim. That's why they like having RCTs when making decisions about whether to adopt something. But then there's observational or quasi-experimental designs. And this is usually controlled, it can be uncontrolled, before or after studies. So you have a baseline measurement, people are not randomly assigned to an intervention or control. The 2 main types that are used in implementation science are regression discontinuity and interrupted time series. There are lots of other types of observational study designs you can choose from. These are just the 2 most common, I would say. And I think these 2 are usually more feasible. So, and I'll walk through these. Quasi and observational designs prioritize external validity. So your results are going to be more generalizable to a real world setting. Whereas with a randomized controlled trial, it's more of a controlled experiment. So regression discontinuity, this is where you have your control and treatment group, and you're classifying them based on a threshold. A common example is whether patients receive HIV treatment, for example. You could look at the CD4 levels as a cutoff, and patients who have low levels are going to get treatment versus high levels or whatever. And that's kind of a natural cutoff. Using a cutoff though can be really tricky. They talk about there being strict cutoffs and fuzzy cutoffs. So if you're going to have an assignment variable, you have to have a really good one. Typically a biomarker is a good one, or lab value is a good one for deciding who's a control and treatment group. Interrupted time series, this is more about policy changes or practice changes. And I think this one's more common because, this one is, that was me, I'm sorry. This one's more common because you have your pre-intervention. So say treatment, we could say something like referral. Say your intervention is referring patients to to use an app. And say you're that, we could use the example from the short course. You have an app that helps manage diabetes. You could look at the referral, you could look at the time before the referral as, okay, this is where patients were in managing their diabetes, or this was their glucose levels. They were referred to use the app. And so what does it look like after the referral? So this is kind of looking at time periods, but you're looking at what happened after that intervention happened. And this happens a lot in policy changes or when practice guidelines change. So if there's a guideline change, you could do something like this, or you're implementing a guideline in the EMR. And then there's alternative designs. Effectiveness hybrid is unique to implementation science. An effectiveness hybrid is actually 3 different types of design, not to make this more complicated. And it has, the designs vary by how much emphasis you put on intervention effectiveness and implementation outcomes. And I'll go through that in the next slide. And then there's that rolled out designer step wedge. And that's where you have units that are in a practice setting and you have them adopt the intervention over time. And I will go over that too. The idea with these alternative designs is you're mixing the strengths of both experimental and non-experimental, so you can have that external validity while kind of building that internal validity. This is not my favorite figure, but it's what it's what I could find that was not just crazy. I need to just make my own figure for this. So there's 3 types of hybrid studies. Over on this left side, you have hybrid type 1. And that's kind of that we're testing the clinical effectiveness of this intervention. And that's kind of where you're looking at information on the implementation. So how did this work in the clinic? Hybrid 2 is you're testing that clinical intervention, but you're also looking at the implementation. And then 3 is testing the implementation of the intervention while you're getting health outcomes from the patients. I almost feel like this is more confusing though, this picture. So it ranges from you're testing it being implemented and you're looking at how the implementation went. So was it adopted? Was it sustainable? Was it feasible? Whereas on the other side, you're just kind of looking at the healthcare outcomes while also maybe looking briefly at, okay, was it adopted? like I said, I think this image is actually more confusing. There's a good paper by Karan about these study designs. The link is on the bottom. If you are interested in this type of design, just contact me and I will send you some information. There's actually a worksheet as well you can work through. Okay, step wedge is where you have a routine care setting and you roll out that intervention over time. So you can see you start with a period of time where it's just routine care. And then you move forward and maybe one unit or one clinic or one, I don't know, hospital gets the intervention, and then you move it up so that everyone eventually has it. And this is a nice way of getting an intervention through ethics, I feel like, because you're kind of letting them know that like everyone's going to get the intervention at some point, and you're not actually taking away routine care, you're just adding the intervention on top of routine care. And everyone has the option to get it. And I have to say, if you're going to do any research study design, you need a person that can help you analyze data. You need a statistician. Okay, so we're gonna go on to qualitative methods and then we'll talk about mixed methods. I'll try to be quick, just given our time. In implementation science research, qualitative methods are usually used to get stakeholder perspectives, inform design and implementation processes, understanding the context in which the intervention is going to be implemented, provide documentation and reflection on the processes. That's usually something you would do during and after, so you can kind of get team members' thoughts on that. Gaining insight on the effectiveness of the implementation, understanding the mechanism of change. And what that means is kind of if the intervention actually caused the change, or if it was just having, well, let me rephrase that. Understanding the mechanism of change is kind of trying to disentangle whether it was the actual digital health technology itself, or if the digital health technology actually changed the behavior or changed the service in some way. And then it's to contribute to theoretical development. And that I don't think a lot of folks will be doing, but that's also a piece of it. In qualitative research for implementation science, you're usually using a purposive, I'm just gonna say purposeful sampling. So you're sampling based on the level of participation in the implementation. So typically you'd be sampling clinicians, end users, stakeholders, anyone involved in the implementation. You could even interview people on your research team. That's a good way to understand how the processes went. And you can do it at baseline, you can do it as part of a formative evaluation, and you can do it at the end as well. Mixed methods is where you're going to combine the qualitative and quantitative. You need to specify a priori, meaning beforehand, how they and when they'll be combined. And mixed methods are helpful because you can get those different perspectives. You can confirm quantitative measures with the experience. You can explain quantitative results. You can textualize measurements, enhance your study results. And you can do this using a needs assessment and program evaluation. I like mixed methods. I think they're useful. These are the different kinds. So you have convergent, which is where you're kind of measuring it at the same time, but then you kind of merge results and compare and then interpret that. There's also explanatory sequential. I've used explanatory sequential before. I think it's useful. That's where you collect, usually it's survey data. You look at the results and then you kind of think, okay, within these quantitative results, what are we missing? What could, strengthen this? What I don't know, what are key questions we still have? And then you can do focus groups or interviews to kind of help explain those quantitative findings. I think this is a good design for digital health as well. And then there's exploratory. This can also be useful in digital health. I think exploratory is really helpful when you're doing kind of a baseline assessment. So you'd collect qualitative data first, look at the results, and you can use the results to develop instruments or inform your intervention. And then you would do your quantitative data collection based on those instruments, interventions, and then kind of look at that. There's other types of mixed method studies, and I'm not going to cover them today because we do not have time. Like I said, there's a lot that is not going to be presented in this just because of the time. But if you have questions or want to know more, you can always reach out and ask, and I can provide some resources. I'm going to talk about data sources real quick. What study design you use is really going to be informed by what data is feasible to collect, how data is generated, when it's collected, and the purpose of it being collected. Like, these are going to inform your decisions. So in quantitative research, you have survey instruments, you have EMR data. EMRs are not meant to collect data for research. So they'll have the data, but there's going to be steps you're going to have to take to get it ready for research purposes. There's publicly available data sets, and then records. Records could be like data logs from your app or website, you know, looking at how people use something. Yeah, like I said, hire and consult with a biostatistics or statistical expert. If you're doing a randomized trial, you can use simpler methods. And then for more advanced studies, you probably need to use more advanced methods. But like I said, consult with somebody. There's a reason why these projects are always multidisciplinary, because you need experts on your team. It's good to be conversant in this so that you understand what's happening, but you don't need to be the expert. You can hire someone to help with that. Yeah, and observational data, you're not going to have balanced covariates. So if you are looking at individual level patients, you can use more advanced statistical methods to overcome bias. But again, you're going to need someone with expertise to help with this. And I'm not going to go into these methods for the sake of time. For qualitative data, your data sources are typically going to be interviews, focus groups. You could do a content analysis, so looking at meeting minutes, policies, guidelines, diaries and journals of patients, or you could do observations. So that would be your field notes or checklists, watching. And observations are interesting because you can even observe clinical teams while they're implementing the intervention. And that can be really useful to see if there's some barrier you didn't know about beforehand. Maybe there's not enough time, or I don't know, maybe they don't like using the intervention. With qualitative analysis in implementation science, you almost always use a thematic analysis. There is a lot of other types of analysis you can use for qualitative research. I want to be clear, like, qualitative research is its own field, but within implementation science, it's typically a thematic analysis. So you're just looking at the data, grouping them into themes, and then you're developing codes based on the themes. And you can use a framework to help guide that. The theoretical domains framework is one that's often used, or you can do grounded theory, which is where you're kind of letting the data speak for itself and you're building up on that. It's not used as often because typically you have a framework that you're using. And so that's, yeah. So anyways, you have your themes, you categorize them, and then you see how the themes relate to each other. Okay, sources of bias. There's so many. You could have confounding, you could have selection bias, you could have just numerator data, and that happens sometimes in hospitals where you're just looking at patients and you don't know the actual denominator of the broader population. Sorry, not in hospitals, but like, let me rephrase that. Numerator data is when you just have the population of patients that you're looking at, but you don't know about the broader population that these people were pulled from. There's response bias, and that can happen with healthy worker bias. So for example, maybe the day you do education and training on your digital health product, there's workers that are not there because they're out sick or something, and so they didn't get the training. And that would mean you would need to provide training in more than one format or provide it on multiple days. There's observer variability. So that would be if you're doing, for example, observations, you need to train people so that they're doing kind of consistently, consistent observations with their methods. There's the Hawthorne effect, where just observing people changes their behavior. There's a regression to the mean that happens when you do a baseline assessment, and then maybe your baseline assessment's like, wow, this is really good, but then you do it again and it kind of all goes back to the mean. This is more in survey research when you're surveying people over time. Sorry, Meg, you look so tired.
No, I was just like, yeah, it does.
Another source of bias is people thinking statistical significance is clinically meaningful. So, and this happens a lot where people think, oh, our intervention was statistically significant, P is less than 0.05. But then you look at the effect size and it's like, oh, your intervention really only changed, 1% or something, like it wasn't very meaningful, but that happens. There could be insufficient power to calculate effect size. That would be more if you're have an individual patients that you're looking at, so you need a sample size. Well, you need, yeah. There is ways to calculate power and effect size, and there's online calculators you can use. It is important to do that for any study, to make sure if you're gonna say, we're gonna find a 10% effect size, you need to have something that you need to calculate that so you know. Cohort effect is when you have the age distribution of a disease that will affect a cross-sectional analysis. I don't think anyone is really gonna do a cross-sectional analysis, but if you do, you need to be aware that older people they have more chance of having different conditions and diseases simply because they've been alive longer, if that makes sense. I know it seems very intuitive. There's ecological fallacy, where you make inferences about an individual when you're looking at group level. So if you're gonna randomize clinics or hospitals, you can really only make inferences on that clinic or hospital, not the individual patients. Bergson bias is when your disease or exposure is over or underrepresented in a population. This is something that happens when you're looking at hospital data, and you guys need to be aware of this. You're gonna probably have an overrepresentation of people with certain diseases or conditions simply because you're looking at a hospital and you're not capturing people who are not going to the hospital. So there's gonna be some differences. It's more that you just need to be aware that you might be seeing more of these, you might be seeing more type of patients than you would in the general population. So for example, if you are wanting to roll out your mobile app to the general population outside the hospital, you might see a smaller adoption, or you may not see as many people using it, just simply because there might be less people with the disease. Undermatching, that's case and control. I'm not gonna really go over that. Testing new diagnostics with a population of patients with a high prevalence. this can make the predictive value higher. And that's if you're, okay, we're gonna roll out a new diagnostic to this clinic where, 50% of the patients have this disease. It's gonna make the new diagnostic seem really good. But if you were to roll it out to the general population, it may not be as well. Missing data is a big problem. With missing data, you're gonna wanna work with a stats person, but you can summarize the missing data and look at patterns of missingness. And I think that's something you can do as someone leading the research project. Say you do a survey and there's missing data, but it seems very random. That's not going to be as big of a problem. It's when you start seeing patterns in that missingness, that's a problem. Like, for example, if everyone is consistently not answering a certain question, that could mean either a lot of things. And that's something where you need to be like, okay, we need to look into this. But there's different missingness. That's all I'll say about it. But look at the pattern of missingness. There are ways to adjust for it. But if the missingness has a distinct pattern, you really can't adjust for that, and that's bad. That's the missing not at random. Missing completely at random, usually you can take that and you can just say, we're gonna analyze the available data we have. And usually that's okay. And then sometimes you can adjust for that, which is missing at random, but okay, sorry, I'll stop talking about that. I'm gonna go over a real world example. What time are we at?
Just at 3:35.
Okay, cool. Before I go over a real world example, do people have questions? And I'm sure there's a bunch.
There's just a couple and they're quite good. So I think if we can have a bit of time to just talk quickly to them. So Rinky is undertaking a step wedge RCT, but also highlighted that there are about 5 main ways to design one, and it's extremely overwhelming. So Rinky would love to hear from you in regards to any specific resources, specifically on designing step wedge RCTs.
Ooh, yeah. Rinky, I have some slides I can send you from a presentation I went to, and I have a couple resources I can send you. Stepped wedge design is really popular in implementation science, and so I can,
Okay.
Oh, that'd be terrific. Thanks, Debbie. That would be extremely helpful if you could send me some resources. The issue with my trial is, so I'm working with a diabetes mobile app and dashboard in pregnancy, and we are hoping to do a cluster RCT plus roll it out at the same time, hence the step plus the trial. However, there are lots of challenges with my patient cohort because the intervals are not going to fit in pregnancy, because the interval should ideally be when they are no longer pregnant, hence we can, but then that overcrosses with setting a time of, say, a 4 or 5 month interval. So I'm trying to get my head around how I design it to facilitate that, but that is really the only design, given we're hoping to do a cluster plus a rollout in sort of this implementation study. So that's really the best design. This has been done in a standard pragmatic RCT in the past, but that's not worked very well. And those authors have said to us, look, if we were to do it again, we would probably do a step wedge. But looking into this, as I said, it's quite overwhelming because there's actually quite a few different models out there of step wedge, and to work out what would completely fit would be, it's a bit challenging. But yeah, any resources would be extremely helpful.
Yeah, that's pragmatic trials are really difficult. They seem like they would be easy, but it's hard. With the rolling out the step wedge cluster, there are designs, and I need to send you the resource. There are more people who are doing more adaptive designs where they roll out the first group, for example, and then they adapt the second group based on what they find in that first group. So
Yep.
if you find in that first group that, okay, this is a bad timing, this would work better, you can kind of adapt it to that. And I can send you some stuff on that as well, because adaptive designs are also a whole other beast. But I think the more simple and the more flexible you can be, the better. Easier said than done, though.
Absolutely. But yeah, exactly that the adaptiveness of it is actually what was also a plus for choosing this design, because what happens with that first clinic and that first cohort, we would, you know, the learnings we would take to the next interval. So that was one of the big motivators of choosing this design for us as well. So yeah, that'd be great. Thanks so much, Debbie.
Yeah, thank you.
And just quickly, Carolyn has a point, and we'll be discussing it a bit next week as well. But in terms of doing research manuscript, any tips on how to present or report the quantitative and qualitative data together, and the best, like as in the best way to format or visuals to have it complement nicely?
Oh, that's a great question. You know, in the past, when I've published mixed methods, we did a table with the survey results, and then we had a section with quotes from the interviews, and that worked nicely. But there's a lot of ways you could do that.
That sounds like it.
But yeah, we could talk about it next week. This case study I'm doing, we just made 2 papers.
So I don't think Carolyn wants to hear that.
No, you probably don't want to have to publish 2 papers, but were those the only questions?
Yeah.
Oh, okay. I'm gonna talk to you guys about another thing I did when I worked at Xenex. I no longer work there, and I am no longer financially tied to them, so I just want to make that clear. What else do I have to say? Is that make it clear I am not an employee. But why I was an employee, I helped work on developing this disinfection tracking system. This is the prototype. This is not what the real one looks like now, but this was 2 studies, but it again is kind of a mixed methods, because we did, well, I guess, you know what, this nurse one, we did surveys and interviews, so this will kind of show Carolyn, this will show you an example. So portable medical equipment has been implicated in outbreaks of hospital-acquired infections. So we developed this disinfection tracking system. We had a bunch of small business research grants, but we developed it to pick up moisture events. So if it got wiped by a disinfection wipe, we also had it detect UV disinfection, and then it had an accelerometer on it, so we could see how it moved around. Yeah, if you ever want to know the story about this being made, we can talk offline. It was definitely interesting. I worked with engineers, epidemiologists, and whatnot. Okay, so we had the first study where we looked at the utility of having this real-time feedback prompt. So we attached them to workstation on wheels. They have those in Australia, don't they? They wheel around the unit. And then vital machines. And you can see this prototype is pretty big. I mean, you can definitely see it. And it shows when it was last disinfected. So, and then the second study was getting feedback from nurses on functionality, accuracy, impact on, you know, care, barriers, and whatnot. So the first study was a non-randomized comparison study of 1 mixed medical surgical unit at the Central Texas VA. We had the screens off for 25 days, and then we turned them on for 42 days. So I should have put the picture on here. It was like this. They were off, that top one, and then we flipped them on. It was on the same unit. And we had them on 10 workstation on wheels and 5 vital machines. And then the second study is a mixed methods. We did focus groups with nurses and then did a survey. So yeah, it was explanatory. Sequential. Okay, so our data sources. For study 1, we just looked at the event logs because those were tracked. Study 2 was a survey and then focus groups. The survey did have open-ended survey questions as well. So in study 1, you can see we were able to capture disinfection events. And it was associated with a small increase in the rate of workstation on wheels being disinfected. The one thing we did find for the most part is, according to these tracking devices, nursing staff were disinfecting equipment according to protocol or hospital policy, which was, that's good, you want that. And then in study 2, we did a survey of the nurses using this equipment. For the most part, I think they liked it. You can see display corresponds to real disinfection, got 5 out of 10. And that's not surprising. I think when the screens were off, it didn't really display. But I'll go into the focus groups because there's interesting results. Yeah, so like sometimes you had to wipe a couple times for it to register. Some of them felt it was too easy to reset without actually cleaning the equipment. When we were developing this, there was a lot of work that went into, okay, is it going to detect moisture and how much moisture? And yeah, it's hard. And we were using off-the-shelf items. So these were just items that we could find that companies already had, because it's just a prototype. But the nurses felt like the information was useful, it was helpful for them to see how long it had been since it was disinfected. And one of them said, I already know I'm going to clean it before I get started, but now I know it is there, so they can validate that it's been cleaned and they can check it periodically. They didn't think there was that much disruption, except the vital machines. That was the nurse assistants. They felt like it resulted in cleaning it more often, which is good. Especially vital machines, those get used a lot. And then the nurses did not see it really changing their workflow. And they thought it would be useful on other types of equipment. And then there was a concern for over prompting. So, and that kind of goes back to this idea of like, oh, it could be reset too easily, or it didn't reset when I wiped it. So, there was concern on that. There was also unanticipated consequences. And these were the questions were asked based on survey results. So some expressed that they were not sure why anyone would try to trick the device, but they were concerned with that. And they were more concerned about people tricking it than they would be about scanning their badges each time. When we were developing this, we were originally like, oh, we're not going to have them scan their badge because we don't want anyone to be, we don't want them to think it's punitive or anything. But then the nurses were like, well, if we scanned our badges, people wouldn't try to trick it. So it was like, well, maybe they do want to scan their badge every time. I don't know. Someone said, I saw a couple of people do that, just wipe the device. There's no way to fix that. It's a people error. Always find ways around it.
Yeah.
But subsequent group discussion indicated that was out of the norm because most nurses want equipment to be clean, which I believe that. One nurse manager incorporated discussions with the staff regarding the PME as portable medical equipment in her rounds and found the display to be useful to clarify policy and to recognize and enforce positive practice patterns. Yeah, so there were some unanticipated, but I think for the most part, there was a consensus that it could be useful. There's a lot of limitations to this though. We did not randomize. As you can see, we just did a before and after with screens on and off. The presence of the device likely changed behaviors. And then there was self-reported information, so baseline compliance of cleaning. And then, like I said, the staff could just disinfect the tracking device itself while not doing the PME. But like I said, I think a lot of nurses wanted to have clean equipment. Oh, okay, that's all of it. Cool. Is there any questions? And is there anything I can clarify on this? Carolyn, I can